Hey, good morning, everyone. Welcome to the UofL Department of Medicine Grand Rounds. I'm Rosemary Youssef. I'm the chief of the Division of Nephrology and Hypertension. So right about now, you're all looking at Jason's email saying, wait a second, this is supposed to be a cardiology Grand Rounds, and it is. I am honored to introduce Dr. Ghafghazi. He's an associate professor of medicine. He trained in the UK, that would be the United Kingdom, not University of Kentucky, and then UT Southwestern. He came to Louisville in 2011 to do his cardiology fellowship, and then he did extra training in both echocardiography and nuclear cardiography. He has a ton of titles, but just to give you the short version, he's the director of cardio oncology program, the section chief of general cardiology, the director of the cardiovascular disease prevention program, and he is the program director, which I'm sure takes the most of his time, reining in all the cardiology fellows. He has multiple teaching awards, both from cardiology fellows and the internal medicine residents. He is doing research on coronary artery disease detection and quantification in a non-invasive manner and has done multiple drug company sponsored trials. He has many oral presentations, poster presentations, and publications. And he is a member of the engineering department, which I guess is the segue into today's topic, which is engineering, innovation in cardiovascular medicine and the role of the physician. So thank you, Dr. Ghafghazi.
Thank you very much, Dr. Usuf, for this very kind introduction. So here's the topic of my talk, Engineering Innovation in Cardiovascular Medicine and the Role of the Physician, exploring the intersection of cardiology and engineering for transformative healthcare solutions. Obviously, I'm a cardiologist, so I'm going to talk about cardiology solutions, but you can apply this to any field of medicine. So here's an introduction. The landscape of cardiology is evolving rapidly, partly driven by advances in engineering and technology. And physicians are not merely end users of these technologies, but key stakeholders in their development and implementation. Historically, physician-led innovations such as pacemakers, heart-lung machine, and minimally invasive surgical techniques have reshaped medical practice. And in the current era, with integration of AI, robotics, and digital health solutions, physicians have an unprecedented opportunity to contribute to the next wave of medical breakthrough. My goal in this talk is not necessarily to get deep into what I've done, but to highlight the role of the physicians and in essentially specifically the topic that I'm interested, which is engineering-driven medical advancements, and to encourage active engagement in interdisciplinary innovations. Hopefully, some of you who have ideas will start thinking about putting them into action, finding collaborators, and moving those forward. Our unique ability as physicians is to detect and define outstanding problems in patient care, which we can use to or take to collaborators and see if there are technology-driven solutions for those. So here's essentially the role of physicians in engineering innovation. It's to identify the clinical needs. As you can imagine, that's probably the most unique part of our role. Spotting the gaps in current care, whether it's a limitation of surgical valve, for example, in the case of TAVR, that I'll point out shortly, and so on. Then obviously collaborating with engineering and provide design feedback with those initial prototypes that essentially are developed. And then after the initial phases of the work is done, you have to test them in clinical trials. And so this is our, again, unique ability to be able to design and lead these clinical trials. And of course, then, but at that stage, if something really shows promise, go to regulators and at the same time, make sure that we have ethical considerations in mind, advocate for our patients in general, not necessarily a given patient, but the score of patients that we're going to treat with these devices and technologies in future. And eventually, some people may be interested to be entrepreneurs themselves. Entrepreneurs have, made a lot of impact in advancement of technology in medicine, and that's something that people can definitely consider. So I'm going to just go over a few prime examples in cardiovascular medicine of this sort of collaboration, a few historical perspectives on heart and lung machine, the balloon angioplasty, and TAVR. So here is essentially the person who takes most credit for developing the heart and lung machine, Dr. John Gibbon. As you can see, a photo of him in the very first prototype that he developed as a heart-lung machine that is used in any form of cardiac surgery. Here to the right, you can see a photo of the very first operation that was done using his device, essentially on May 6, 1953. So if the famous Dr. DeBakey, probably the most prominent cardiovascular surgeon who has lived so far, met Dr. Gibbons and learned about his challenges in developing the heart and lung machine. And the part that he didn't like was the pump mechanism. Now, interestingly, Dr. DeBakey was a medical student in Tulane and worked as a technician in a research lab. And his advisor was interested in pulse waves. So he asked him, or he assigned him, to find a pump that can be used in study of the pulse wave. He went to medical library, didn't find anything. He had a friend who was an engineering student, went to him and said, well, you went to the wrong library. Obviously, those days, there's no internet or any of that. So it was all paper. And so he was guided to engineering library and, figured out that pumps have been used for 2,000 years. Eventually developed his own pump, the roller pump. Which, when he had that discussion with Dr. Gibbon, he suggested maybe if you have a problem with your pump, you can use, the pump that I developed decades ago. By this time, he was essentially the chief of cardiothoracic surgery at Baylor in Houston. And so, eventually his pump was incorporated into the heart and lung machine. So here's a collaboration between a medical student and an engineering student that eventually makes its way into heart and lung machine and revolutionizes cardiovascular medicine. This is a schematic drawing of the DeBakey pump, roller pump. This is the pump that was eventually incorporated. In fact, if you go to the operation OR these days and watch a CABG or any other cardiac surgery, they're essentially still the same roller pump that DeBakey came up with. On the right, you see a photo of DeBakey here with Dr. Gibbons, and he was given the Lasker Award, which is called American Nobel Prize for essentially inventing and developing the heart and lung machine that made cardiovascular surgery a lot more safe than what it was before. Okay, so the next one, balloon angioplasty, and Dr. Andreas Grunzig. So he was a Swiss cardiologist, and he pioneered PTCA, or what's called today PCI, for coronary arteries. Before that, the same technology was used, in fact, in peripheral artery disease. But of course, coronaries are smaller arteries and more difficult to reach. And a lot of work was done before he essentially developed the PTCA. So, he stood on the shoulder of the giants, but he refined the balloon angioplasty for coronary arteries and did the first procedure in 1977 in Zurich in a patient with coronary artery disease, who at the time was felt to be obviously a very important innovation, and again has shaped and changed cardiovascular medicine infinitely since then. Here is Dr. Grunzig with what's called the Judkins catheter. This catheter is still very most commonly used catheter in diagnostic coronary angiography. Here is a photo of, in fact, he developed a peripheral artery angioplasty catheter beforehand. This is a photo of that very first catheter that he developed and a photo of the patent that he filed in 1980. or in fact earlier, but was granted in 1980. He made those catheters essentially on the kitchen. This is his kitchen. This is his kitchen table in Zurich. And this lady is his assistant, and her husband was an engineer who helped essentially develop these catheters. So here's another collaboration in somebody's garage, in this case, kitchen, which essentially completely changed the shape of cardiovascular medicine. And here's the last example, TAVR. In 2002, the first TAVR was done. Before that, in 1989, Henning Anderson, which was an engineer, invented the first transcatheter heart valve, which was a handmade metal stent, and porcine aortic valves was essentially used to develop that. He did essentially an animal trial and showed that this was successful, published in 1992. However, it took about 10 years, and Alain Cribier, who is a French cardiologist, performed the first TAVR essentially in 2002 successfully in France. So this is a photo of that very catheter that they used. They used a 30 millimeter balloon, which if you think about coronary arteries, these are big balloons, usually not necessarily used in not used in coronary arteries at all, used in peripheral arteries. And so they essentially crimped a valve on top of the balloon and did what's called an antegrade approach. As you can see, nowadays, if you're aware, the TAVR valves are done from femoral artery approach by sticking the femoral artery, and the catheter is retrogradely moved to essentially the position of the aortic valve. But at that time, they went femoral vein, went all the way up to the right heart, crossed from the septum to the left heart, went from the left atrium to the left ventricle, and so that was an antegrade approach. What you can see here on this photo is the balloon that's inflated. You can see the valve essentially sitting right here on at the position of the aortic valve, the valve that was replaced. And I'm going to use my laser point here. So here's the valve that was replaced, and then they did essentially an aortogram and showed that the valve was actually sitting there and stable. So this patient was a 57-year-old male with severe aortic stenosis and peripheral vascular disease, came in with cardiogenic shock, wasn't a candidate for any type of surgical procedure. They did a balloon valvuloplasty, which is essentially a balloon that goes in, you inflate that up, and you sort of break open a very stenotic aortic valve, hoping that you get a bit more flow. The problem is that it doesn't last that long, sometimes lasts only a few days, and that's exactly what happened with this patient. So the patient was essentially dying, and they decided to just go ahead and do that. And, they, again, very much, arguably, the biggest innovation in the last 20 years has been TAVR in cardiovascular medicine. This patient, by the way, lived for 17 weeks and in fact died from a non-cardiac complication, given all his comorbidities. All right. So what's happening today in this field? What are the engineering sort of fronts that people are striving through? So obviously AI is top of the list for everybody, arguably in a lot of other fields also. But nowadays, people are working on 3D printing to develop custom prosthetics, as opposed to prosthetics that are created the same for everybody, including heart valves and otherwise. Robotics, wearable technology has been very hot with smartwatches and biosensors, and of course, biodegradable stents. So just a slide on AI, given its a significant prominence these days. In cardiology, deep learning is done and currently pursued in echocardiography and advanced cardiac imaging for automatic interpretation. There's a lot of focus on AI-powered ECG analysis. People have published the ability to detect LV dysfunction, essentially heart failure, with reduced ejection fraction from an ECG alone. Arrhythmia detection, which has been around for a long time, but now more sophisticated. Silent atrial fibrillation, this was very interesting. So this were a group at Mayo that were able to detect atrial fibrillation from an ECG in normal sinus rhythm that was done within a month prior to that very first episode of AFib captured on ECG. And so that's why it's called silent atrial fibrillation. Hypertrophic cardiomyopathy and determining patients' age, sex, and race just based on ECG alone. These are the things that have done in the field of ECG and AI-powered analysis of that. And finally, wearable technology is all dependent on AI and is pursued nowadays pretty significantly. A lot of companies involved trying to bring these technologies to the fore. So I'm going to switch gear and talk about a bit of work that I've done. Again, as I said, my intention is not to have a deep dive in this, which is not necessarily something that is of interest to the audience. It's more to kind of describe the things that I have personally performed and hopefully encourage others to look into their own fields and interests. So we use a technique called fractional flow reserve, or FFR, to measure pressure loss across coronary stenosis. As you can see on this schematic, you put a pressure wire with a sensor after stenosis and a sensor before the stenosis, and you measure that pressure loss across the stenotic lesion. This is nowadays considered the gold standard for quantifying the degree of ischemia in patients with stable coronary artery disease. This is in context of ACS, used in a different fashion, but not necessarily this used essentially for the lesions that are not the actual target lesion for acute coronary syndrome. So if there are other lesions that can be used in that sense, but mostly in stable coronary artery disease. However, it's not used that often. A lot of times still visual assessment of coronary stenosis is done. And the reason for that is because this FFR, as you can see here on the right panel, it's time consuming. Obviously, there are costs associated with that. And of course, there's more risk of complications, especially the more severe the coronary disease gets. And those are coronary dissections and pericardial effusions and so on and so forth. However, the benefit is obviously it allows you to do this objectively as opposed to subjectively by estimating the degree of stenosis. And there's some data, not as strong, but data that suggests that it can improve patient's outcome. So FFR is the gold standard in quantifying coronary stenosis. And if you're able to do this computationally, then you could have all the benefits and perhaps forego the risks and complications and costs. So this is the work that we did with my collaborator from the Speed School of Engineering, the Department of Chemical Engineering. They used a method called computational fluid dynamics, or CFD, and developed a model. Now, this work was this type of work was already done in CT coronary angiography. However, we developed a model for coronary angiography. And I'm going to just show you a quick slide on how our model performed. This was the derivation cohort. And as you can see, whenever you have 4 quadrants, but your dots are in 2 of them, hopefully if those are the 2 quadrants, that looks very good. So here are the true positives. Here are the true negatives. And of course, on this side are the false positives and false negatives. And as you notice in our derivation cohort, if you're close to this line, that's like 50-50. That's your coin toss. But our model performed very well with sensitivity and specificity, both above 95%. And the work was published essentially in scientific reports. And then we did a validation study on a different cohort. Of course, always your derivation cohort looks very, very good because that's where you fit your model. But even in our validation cohort, our model performed very well, as you can see on this graph over here, compared to, now we call this virtual FFR, and compared that to the gold standard, which was the invasive FFR. Again, you can see the sensitivity and specificity, both again still above 90%. So here is a if I can make this. This is a video. So I apologize. I'm going to go back to my arrow and show you this work. So this is essentially a summary of the work essentially we did. So here's a coronary segment. Here's the proximal part of that segment. Here's the distal part of that segment. All of this flow that you can see through this coronary artery in essentially during one cardiac cycle is computationally essentially assessed and developed. So this is not real blood flow. This is essentially a computational depiction. As you can see in a coronary stenosis, you have some essentially stagnation of flow right after the stenosis, which increases the time of blood flowing, which was the model we in fact used for assessment of coronary stenosis in this project. This type of work, in addition, I want to point out that it allows you to also be academically productive and publish papers. So we've published 2 papers so far. We actually have another 2 that are essentially being worked on, and hopefully one submitted and the other one perhaps soon to get submitted. So this is the first project, which actually I started at the end of my fellowship and continued the first few years of my faculty position. About a couple of years ago, so I'm moving to the next project. One of the emergency department faculty, Dr. Hecker, approached me about this other project, cell phones as diagnostic tool in cardiology. So well within the realm of digital health. And here's sort of the idea. There are 8 billion cell phones worldwide. FDA considers them, in fact, this was an interesting fact when I heard about this. FDA considers cell phones as stethoscopes since 2019 under this section of the rules called 510K, which is commonly used for these diagnostic devices that are that go through the FDA approval process. The recording speed, however, is up to 50 times faster than you get from a lead-in digital stethoscope. So phones can detect very fine dynamics. And so I started, obviously, I was very interested in this field, and so I was very happy to collaborate with Dr. Hecker and the local engineer who had developed this technology. So the way this technology works is you grab your cell phone. It could be a $50 cell phone off of Walmart. It could be Android or iPhone or anything else, and you essentially put that on your aortic area where the microphone is, and you record based on an app 30 seconds of your heart sounds. Now, the heart sounds that you record, a lot of that is actually under the threshold of detection for human ear. So there's a lot of data that you can record in 30 seconds on a patient. A lot of that, if you listen to the actual recording, you don't necessarily pick much up beyond what you hear, in fact, with your stethoscope. But then this data is used, with this data, the idea was, can we develop cardiac diagnostics on these patients? And now, without necessarily, again, trying to go to a lot of details, this wasn't the classic AI. The model that this engineer had developed was essentially using the physical parameters of the sound. And his argument was that as opposed to AI, which sometimes may not perform well when it is applied to the sort of population that was not involved in the training of the model. Because this was essentially based on physical properties of the sound, the result, was going to be essentially more reproducible than standard AI. So here's essentially the first project that we finished, led by Dr. Hecker out of the emergency room, the technology was able to very successfully detect patients based on a dichotomy of EF less than 40% versus EF more than 40%. As you can see here, these are the true positives. Again, you kind of see 4 quadrants. And you want to have them in most of your dots in 2 of the quadrants. This is the true positive. This is the true negative. And then you have some false positives over here and false negatives. But as you can see on the table over here, this is, this was very successful. Obviously, again, derivation cohort, so it needs to be validated, but a sensitivity of 95%, a specificity of 95%, and accuracy of 95% was essentially the result of this work. So then we moved forward and said, okay, can we use this technology to detect volume overload? So this is a project that I essentially led, and we enrolled 200 patients out of cath lab patients who were going to undergo right heart catheterization for clinical indications. This is unpublished data, but again, you can see that based on right atrial pressure, there was, again, a binary model developed separating patients to right atrial pressure more than 7 millimeters of mercury, which was defined as volume overload, and right atrial pressure less than 5 millimeters of mercury, which was defined as euvolemia. And as you can see, again, the model, most of these dots fell into those quadrants. And then, of course, you had some false positives and false negatives, but pretty acceptable sensitivity. It wasn't about 90%, 89% sensitivity, and a specificity of 84%. And when we did the same thing based on a pulmonary capillary wedge pressure and defined more than 16 as volume overload and less than 12 or less than equal to 12 as euvolemia, again, the model performed pretty equally based on this parameter with a sensitivity of 84% and a specificity of 91%. So this got us excited. So we have essentially a technology that's able to say, where if your ejection fraction is preserved or not, and it's also able to say if your volume overloaded or not. So we thought, well, if we put this both together, can we do something about this? And can we do essentially both of these things together? So this is essentially how we've defined our next project, but we've essentially done all of that based on echocardiography. As you know, in echocardiography, you're able to assess the ejection fraction, obviously, but you can also detect the volume status based on the size of IVC and diastolic function. So this project is well underway. We've already enrolled close to 500 patients. We're hoping to enroll about 800 patients and complete the project. So if a technology like this is developed, you can imagine the use of that in a lot of spaces. So frontline medicine like EMS or disaster response. Again, think about it. All you have to do is put your cell phone in your aortic area for 30 seconds, and the data goes through the app. But the models are developed, so you don't need to. When models are developed, all you have to do are a bunch of math, and those are done in fractions of seconds. So you can do this with 30 seconds, and in fractions of seconds, this can tell you if the patient has what sort of ejection fraction in a dichotomous fashion. Obviously, it's not an exact number, but also the volume status. And so you can imagine the use of that in telehealth, in rural medicine, in medicine in underserved areas. A patient shows up is somewhere with perhaps a right out of school nurse practitioner with shortness of breath, and think about your differential diagnosis with shortness of breath. It could be anything, right? So this can go a long way to help people determine if this is something related to the heart, at least rule that in or rule that out, and hopefully help the patient get to the treatment they need as soon as possible. But other places that you can use this is because this is such an easy and low-cost technology, it can be used in telehealth, in long-term monitoring. You can think about humanitarian use and so on and so forth. So you can imagine these things, doing this sort of work. Obviously, not everything is a TAVR or a heart and lung machine, but it can certainly help address some of the needs that you struggle in the current environment to develop.
Okay, so after these couple of projects, I'm going to tell you about what's happening at UofL. And I start with Bluegrass Biodesign. So this is a program that started in 2021 by a former medical student and a future ENT surgeon. As you can see his photo, Ankur Gupta, and started with 3 teams. And the idea was essentially teach third-year medical students this whole process and encourage them to get engaged, develop those, find those questions, develop those collaborations, and perhaps come up with these technological innovations. Now, the most famous program of this sort is at Stanford. There's a program called Stanford Biodesign, world renowned, probably the best anywhere in the world. With more than in fact, when I was looking up for this talk, and perhaps a 200, that's what they coded, 270 of their innovations has essentially made it to commercialization. So that's a massive program, and it's not in medical school. That's essentially a 1-year fellowship. They have a lot of different programs. They have courses, programs, and fellowships, but it's done. It's not for medical students. It's for physicians. Most of them are essentially after their residency training. Here's the very first 3 teams that were essentially involved: neurosurgery, ENT, and our dean of medical school at the time, chair of the department of otolaryngology, was part of this, and of course cardiology and cardiothoracic surgery. I was delighted to be part of the mentoring faculty group for cardiology. We also had Dr. Enge from Pomcret, who was a faculty member, a mentoring faculty member for the medical students. It's essentially a collaboration inside the university between the medical school, the School of Engineering, and in fact, now the College of Business has been engaged, because the idea is to teach people about the whole process, that collaboration, and then developing a business plan and perhaps moving that forward. You can see the folks who are involved from the medical school: Dr. Kim, who is now the Vice Dean for Innovation, and Dr. Sperling, both from Department of Pediatrics, are essentially directors of this course. And 30 medical students can apply, and if they're accepted to the program, they're now essentially 10 teams. One of them cardiology, cardiothoracic surgery, and in fact, there's another one for pediatric cardiology. And here's sort of the big picture process that it's very sort of common sense, and I sort of alluded to that through this. You identify a problem. You make sure that you go through that and make sure that is an actual problem. Sometimes something that comes across as a problem in your first glance ends up being not necessarily such a problem worth spending your time on. But then you move through the invention process. This is where you collaborate with your engineers. You generate the concept, you screen the concept, and move that forward. And eventually, you develop a strategy and a business plan to move this process forward. So medical students go through this process. This is a 9-month program through their 3rd-year medical school. It is not easy, because again, they're 3rd-year medical students, so they have a lot of work to do already. But they have classes for this course, and they're essentially lectures and so on. And of course, they have to choose a project through this process and move that forward, ideally to all the way to the prototype of whatever they've come up with. But they get lectures from, again, related to all of these concepts, and they're assigned to one of these teams. Again, for the last 3 years, I've been the faculty mentor on the cardiology team, and I'm going to share, in fact, the project that this graduating class this year, they just finished, in fact, about a month ago. And I'm going to share what the work they did, which was, very impressive, and so I want to give them credit for the phenomenal work that they did. So their product was flex patch pacing wires. And so here's the idea. By the way, here the medical students who did the work, Sidney Johnson, Quentin Wise, Mohammed El-Ez, and Sid Mohammed Al-Mustafa. Here are the medical students, are the engineering students. So when they go through the engineering phase after finding the need, then they start collaborating with engineering students from the speed school. And as you can see, there's a clinician, and they're essentially faculty from engineering school who supervise the engineering students. And this collaboration is developed that way. So the students start with shadowing clinicians. In fact, for cardiology, I take them essentially to cath lab, to the ICU, and then they spend time in the OR with cardiothoracic surgeons. They spend time in heart failure ICU. They spend time in EP lab. They spend time in cardiovascular surgery ICU. All of those places in trying to find the problem. So this year, one of the students asked, as they were going through this process, asked one of the cardiothoracic surgery fellows, what can we do to make your life easier? And the fellow said, these temporary pacing wires are the bane of my life. If you could, I wish we had a better technology available. This was their project. So now the temporary pacing wires, every time an open heart surgery is performed, given the risk for having heart blocks, these temporary pacing wires are placed. As you can see on this photo, they're essentially sutured epicardially on outside of the heart. There's usually an atrial wire. There's a ventricular wire. Get my laser pointer here. So atrial wires and ventricular wires. So the wires, as you can see here, here's the blue that you can see here is the wire. And at the tip, you can see the suture. So the wires are connected to a suture. And when you suture that to the epicardium, then you connect that through these outside wires, and this is essentially the pacing box. So it's done essentially for any heart surgery. And then these are temporary, then you pull them. You literally pull them, off the heart. However, this whole process, again, you're using a needle. And then you have to pull, then you after suturing, you remove the needle, but nonetheless, you've sutured, and so there is actually a risk of cardiac tamponade in 1 in 1,000 cases of using these temporary wires. These are the other complications that could happen. But if you just focus on tamponade, that happens in, again, 0.1% or 1 in 1,000. And the average, you can see what happens when you have cardiac tamponade after heart surgery. So your average length of stay goes from 12, 13 days all the way to 35 days. So there's an extra 21 days on average of essentially having to stay in hospital when you have such a complication. So here was the problem, that unmet need that they essentially set out to try to find a solution for. And this is what they come up with. They thought, okay, if we were to, by the way, I'm again summarizing, they actually looked at what was available in the currently. So as we said, you can't just say, okay, here's the problem I'm going to go after. So solving this, you have to look and see has anybody else tried to come up with some other solution? Maybe they already have solved it. Maybe that's not made it to our center, but it's out there and available. But so all of that work was done, and there was nothing really that could address this problem satisfactorily. So they decided to work with engineers, and they came up with this idea of using adhesive patch for essentially easy placement, because obviously there's no suturing, which is not really suturing of these wires is very easy for CV surgeons, but really the safe removal is the most important part. So they use a biocompatible, biodegradable hyaluronic acid hydrogel in the prototype, which had insulation and adhesive essentially characteristics that made them essentially suitable for this. And this is the actual photo of the actual prototype that they actually developed with the engineering students. So this stuff that you can see here all the way to there, these are essentially outside the body. That's the actual wire from here on. It could be inside the body, and this is the patch that goes essentially on the epicardial tissue. And so, as you can see, this was they did phenomenal work with coming up with this idea. Obviously, this is a prototype, And it needs to be optimized. You have to make sure that this can form a very good, reliable adhesion, that it can essentially insulate so that you don't end up with arrhythmias from electricity going the wrong places. And of course, you have to make sure that this biodegradable product that they develop in animal studies is going to be safe. So there's still a lot of work to be done, but you can see in a short 9-month program for third-year medical students, they did a phenomenal work with this flex patch pacing wire for essentially this problem. Just to quickly show to you that as part of this course, the students are also exposed to market analysis. Now, I don't want to go through this. I just want to show you that they actually do that for the product that they come up with. They essentially come up with this sort of elevator pitch. If you're going to essentially, try to get investors to invest in your product, you're going to have to tell them why this is going to work. So here's, for example, the work that they did. They said, okay, if you have 1 in 1,000 patients with tamponade after heart surgery, we're going to have 450 cases a year in the United States, based on the number of surgeries that are done in this country. With the cost of ICU stay, staggering cost of ICU stay, an extra 21 days, this is the cost saving you can do per year. And we're not even talking about the medical legal aspects, the physician burnout from these complications, and so on and so forth. So there's probably a lot more cost saving by such a technology. This is just by freeing up ICU beds that can be used for other patients. And they also do a cost analysis and how much it's going to cost and so on and so forth. Again, I'm not intending to go through all of this, just to kind of show you what this course is all about. Okay, so this has become very popular for third-year medical students. And I want to encourage faculty, if you're interested in mentoring these medical students, or you have ideas that you want to work with medical students to move forward, this is certainly an opportunity to do that. And I can certainly put you in contact, or you can reach out to Dr. Kim, or I can put you in contact with him if you're interested to do something like this. Okay, shifting gears for my last few slides, and just tell you about what's available at the university level. So UofL has been very interested in encouraging this sort of academic endeavor. And there's been a lot of grants, essentially, that center grants that are used for intramural funding at UofL. As you can see, here's the sort of grants from 2012. In fact, for that very first project that I presented to you for coronary flow reserve, we got a 250K grant from Excite program to do that work. So currently, the NIH REACH is available. If you pay attention to the announcement from the there is an email that is sent on a weekly basis that essentially has announcement about these grants being out there, 2 or 3 of a cycle of these per year, if I'm correct. So there's intramural funding for this. There's also extramural funding for people who are interested. Here's essentially the slide that these slides I borrowed, in fact, for Jessica Sharon. So I have her email here, and Will Metcalf. These are the folks at the research part of the university that deals with that stuff. They can help you with technology and product development. They have helped people with industry partnerships, with intellectual property protection. That's very important. University, in fact, is able, willing, and has this infrastructure and ability to essentially develop the IP protection for the project or the product that you come up with, the technology that you invent. They can put you in contact with startups, new ventures. There's also entrepreneurial training opportunities that you can use. There is entrepreneurs in residence, essentially at the center that they can put you in contact to help you essentially develop those the business aspects of what you've done, and eventually they help through the licensing opportunities. So if you had any projects that you wanted to develop, you can certainly contact Jessica or Will, and have a Zoom call with them and go through the process and see what they can help you with, or who they can put you in contact with. So here's sort of the almost a summary slide, maybe my penultimate slide. So you can, if you want to do this, join interdisciplinary research teams, engage in such fellowships such as I mentioned, Stanford Biodesign. That is a phenomenal course if you're interested, but that is after folks have probably finished their training. This is a full year dedicated program. There are hackathons and innovation challenges that are announced all the time, and of course, intramural and national innovation or small business innovation research (SBIR) grants that you can apply to for projects like this. So here's my final slide. Engineering innovations continue to transform medicine. Physicians must be active contributors to technological advancements, and encouraging interdisciplinary collaboration is essential. So hopefully some of you will do that. We'll start finding a clinical problem and move that forward. Thank you.
Thank you, Dr. Ghafghazi. Dr. Usef, or if anyone has a question, you can unmute and ask, or if you want to post it in the chat area. Guys, that was some really cool stuff.
Yeah, absolutely. This is so exciting things that you all are doing. Who is helping you all go through the IRB, like clinical trials part of this? Do you have help for that also, or is it just the production part?
Right. That's nothing specific. Essentially, you treat this like any other research project. And if you have funding, obviously you hire people that help you through this. If you don't have funding, hopefully you have medical students, residents, and so on who want to develop. And in the beginning, you need to develop some sort of idea. But I encourage people to look for grants. It's actually very doable if you have an interesting project, an interesting idea that you want to move forward with. Developing a little bit of preliminary data, you can definitely get those grants. I think those are easier than, let's say, a standard R01 grant that you want to get from the NIH. These are developed for folks that, this is sort of our powerhouse, right? We're not competing with, pure scientists who spend their life, that's all they do. So this is a field that really is unique to us, and there are mechanisms for funding this stuff. So I think people, if they need help beyond, let's say, by the time they get to clinical trial, for sure you must have developed, you must have secured grants. I don't know that you're going to be able to do that without. And hopefully your project or your technology is exciting enough that people want to invest in that, or want to collaborate with you at minimum to try to develop something like this.
So are the students who want to participate in this, are they signing up in their medical school class? Is that how they're doing it?
The Bluegrass Biodesign, yes. This is essentially open to all third-year medical students. They apply, and if they're accepted into the program, and they do take, there's 4 students per group, and now there are 10 groups. They started with 3, so now there are 10 groups. So they take, I believe, about 40 medical students, if not more, because I've seen some of those groups had 5. My group has always had 4 students, but some of them have had more than that. So they take a few, 40 to 50 essentially students. But if this is something you're interested to do, you can certainly, for example, urology is there's a urology group, but urology and nephrology, the same as cardiology, cardiothoracic surgery are combined. Urology and nephrology can be combined. So that could certainly be a project that that the students can start working on and develop that very first prototype. But then, I'd say one of the issues with the way this is set up, obviously, is that, again, when you have 30 medical students, I mean, they're so busy trying to learn medicine. And then, of course, they're going to be fourth-year medical students. They have to apply to residency and so on. So when they get to this level, then you need to have a mechanism to then move this forward. And so that's been, something that, we've been thinking about, how to develop that. We don't have any concrete plans yet, but, that's where this thing is.
Jason, it looks like someone's hand is up.
Dr. Sameh, would you like to, you can unmute and ask your question for Dr. Ghafghazi if you'd like.
Of course. Can you hear me?
Yes.
Oh, perfect. Thank you very much for a wonderful presentation. My name is Omar. I'm an MD, and I'm currently doing research regarding AI applications in medicine here at UofL. I just wanted to quickly, ask a very brief question regarding your project on the, virtual FFR, whether, you are developing this model based on virtual, virtual generated data using simulation models of computational fluid dynamics, or whether it is based on actual data that is captured by sensors or, any sort of imaging modality.
Right. So this work actually was done on both of those. So the initial work was done on model arteries. Essentially, these were arteries that the graduate student who was working on this literally created himself on his software. But then, after he had an initial model, we secured a grant through the Excite program, and were able to get actual coronary angiographies from patients and develop a 3D rendering of, as you know, coronary angiography is a 2D technology. There's technology out there that you can essentially make a 3-dimensional segment of an artery. That was the video that I showed, was an actual coronary artery of a patient, the 3-dimensional rendering of that. So we then moved on to real patients based and developed a model on patients on actual coronary angiographies, and then the validation was also done on actual patients.
Perfect. That is wonderful. Thank you very much for the explanation.
All right. If anyone else has a question, you can unmute and ask, or if you want to put it in the chat area, or Dr. Ghafghazi, you covered the bases so well. There's nothing left to cover. Anyway, Dr. Rousseff, would you like to maybe do a quick wrap here? And
Well, I don't know. Jason's now added a quick wrap, but thank you for this fantastic talk. And I'm sure a lot of medical students who are listening are kind of excited, and maybe will start joining you.
Yeah, we look forward to that and working with medical students. The amount of the energy, enthusiasm that they bring is just unparalleled.